Friends, welcome to Tots to Teens Tidbits. We are here today. I'm so excited you're joining us for a very important topic. As of course, I think all of our topics are important, but this one is near and dear to my heart. We're going to be learning how to be a masterpiece patient advocate. And this is something that I think we touch on in our training. We learn a lot about the dermatologic conditions and the biology of that, the pathology of that, the therapeutics of that, and that's all really important because as a dermatologist, that's what people come to see you for. But they are also looking for dermatologists to address their social, emotional, and spiritual aspects of their condition. And again, that is so much why. That is really the reason that I started Made a Masterpiece, the only 501c3 in the whole United States supporting social, emotional, and spiritual aspects of living with a skin condition. And this is an initiative through Made a Masterpiece. And if you complete a module, this educational module that I'm going to share with you tonight, and you take a quiz afterwards, you will get a certificate that you can proudly display in your office, but you will also just get the benefit of knowing that you understand the social, emotional, and spiritual aspects that your patients might be battling with, and you'll make a stronger connection. And when we have stronger connections with our patients, we have a better therapeutic alliance. They are more likely to be compliant with treatment, happier with you, and there is less chance of malpractice. But again, we just want to take good care of patients. That's why we do what we do. So let me go ahead and share my screen, and we will jump in to the educational module here. All right. And let's open this up and get rolling. Okay, so how to be a masterpiece patient advocate. So what we want to do when we are masterpiece patient advocates is to make every patient feel like they were made a masterpiece. And it's sometimes hard to connect with patients, but I do think that addressing their whole person is an easy way, and it differentiates you when you really care about your patients, I think, and address these issues. So this is the educational module. It was written by Emily Struphauser. She is a Baylor medical student. She is amazing, and I love working with her. She is very on the ball, and she is just really incredible. I can't say enough good things about Emily, and we had a good time working on this, and it is going to be living on our website soon. And then when you do get that badge, the Masterpiece Patient Advocate, you can also display that on your website in the future if you're in practice. So basically, we are just thankful that people want to invest. And I will say that I think the younger generation of physicians are really great at the overall care and well-being of their patients and just addressing the whole person. I think that is something that some of us older physicians weren't really educated about, the importance of it. And again, I have a lot of hope for the future for all the future dermatologists that are out there. So again, excited to be sharing this with the world. So we're going to jump right in. And so visible derm conditions, they can have a significant impact on the psychosocial development and especially the mental health of children and adolescents. And really what breaks my heart is it does lead to increased development of poor self-esteem. They have strained interpersonal relationships, and then they have psychiatric comorbidities. And that's really what this talk is all about. It's just the anxiety, depression, and suicidal ideation that these patients face. And really, especially if it's on a highly sensitive area, the impact can really trigger emotions such as shame and guilt and embarrassment among our young patients that we take care of. And they can start to develop as early as 3 years of age when they start to see themselves in the mirror and recognize that they may look different. And by the age of 7, they really can notice socially conceived aesthetic differences between them and their peers that impacts their self-worth and self-esteem. And it can really impact a child's motivation, their self-confidence, their resilience. And we know that children that have skin conditions, they They don't participate in sports as much, just because more of their body is exposed. So again, these children really do suffer in a lot of ways that we may not just see in the clinic. And really, this is something that I think is very interesting, that the severity of the clinical presentation may not correlate with the impact, the psychosocial impact that it has on our patients. So something that you may consider quite mild may be very significant for our patients, and things that are actually very significant as far as body surface area may not really have a huge impact on the psychosocial and, standing of our patients. So unless we ask the questions or bring these up in our clinical interactions, we won't understand. But, it is important to screen for mental health concerns, I think, in all children and adolescents. And there's a lot of just short one-pagers that can give you a simple score. They can do those in your waiting room. And those are very helpful, and just seeing where your patient stands so that you can provide them the best possible care and connect them with resources that may be helpful and their quality of life. So we'll just jump in with acne vulgaris, and Emily went through all of the pertinent literature in regards to the psychosocial comorbidities related to living with a skin condition, and many of the common conditions that we see. And so this is sometimes surprising to me how much of a negative impact acne can have. And I know we've all seen this. And sometimes the acne actually isn't even very severe, and it really, really impacts these children. And just one anecdote, one little story. When we were at Children's House for the Soul, and we had Lindsay O'Sullivan on staff as our child life specialist, she actually met with this little girl who had just developed acne sooner than her peers. So she had kind of early onset acne. The rest of her peers really hadn't started to develop it. And so she felt very different and singled out, and really her self-confidence was shaken to the core. And Lindsay helped her write kind of a theme song when she entered the room that she could kind of play in her head, that she was worthy. And she came up with some great words. And yeah, that made all the difference, because again, when we walk into a social situation and we have a skin condition, we're always, thinking that everybody is seeing that over the person that we are inside. And a lot of times they really are. So anyway, acne vulgaris, you guys know it's a chronic inflammatory disorder. And then there's comedones, papules, pustules, nodulocystic lesions. It usually starts between 12 to 14, and it can manifest earlier in females especially, and then 95% of adolescents will have experienced some type of acne during their childhood and their young adulthood. And it carries a significant burden. And I know that you guys have seen that. And it's not just on children, but adult acne also carries a significant burden. And a lot of our patients that have adult acne didn't even actually have it as a child or a teen. And they really struggle with it. So it is thought to be due to poor hygiene a lot of times. And that really can be difficult, because we sometimes reinforce that as dermatologists as well, because really, even if a kid is taking good care of their skin and they have hormones and they have a family history of acne, no matter how well they're taking care of their skin, they're probably going to get acne. Now, we know that cleansing the skin is important for that, but when we tell them that, it's their fault, we're just really inducing a lot of shame. And the parents are already doing that at home, a lot of times unconsciously. So again, it's good for us to ally with our young patients and tell them, that the skincare is important, and we know that as dermatologists, but that even with the best skincare, they may still break out, but it will help them to have a good regimen, and you'll partner with them. And again, we know that it can impact the embarrassment, self-consciousness, and then social dysfunction that results in decreased peer interactions and participation in sports, like we talked about before. And they've done some large-scale studies with clinical anxiety in pediatric patients, and they found that they were 2 times more likely to have symptoms of major depressive disorder and anxiety. And even when they adjusted for the symptoms of depression and anxiety, I think this was really telling. They had a 1.8-fold increased likelihood of attempting suicide. So there have been other studies that have also reinforced this, and that suicidal ideation is quite prevalent in our acne patients, and more so in boys. So again, it's important to address that, even when it's just a general acne patient. I think it's important to bring that up and ask, just how is this affecting you and your life, and how you feel about yourself. And then alopecia areata, I think this is one, in my experience, that induces a lot of panic and fear in patients. And again, I'm sure that you guys have seen that, and you'll see it more as you continue to care for patients throughout your career. But families really, really worry about, this progressing. And I think what makes this and vitiligo similarly stressful is just that the disease is so variable and so unpredictable. So, you may be going along fine and have, maybe one patch of hair loss, and all of a sudden you start noticing your hair coming out, and you automatically start to panic that you're developing new bald patches. And it might happen, right, where it's pretty quiescent for a while, the disease process, and then all of a sudden it kicks up. Because of unknown factors or maybe stress. And then, of course, that causes more stress, and then that feeds into the cycle. So parents with alopecia areata do tend to be quite anxious when they come in with their children, because they're seeing hair in the shower, and they're seeing hair in the brush, and they're seeing hair on the pillow. And again, it's really important to understand that they may be upset that we don't have a lot to offer. And luckily we have more and more to offer with the new drugs coming out. But just understand their perspective, that they're scared, and sometimes that anxiety is going to come off negatively to you as a provider, but you can't take it personally. So we do know that alopecia areata targets the hair follicles, leading to those bald patches. And we know that it affects about 1 in 1,000 children. So about 1% of the population overall, more likely to be more severe if it begins before the age of 5. And then they've also shown recently that Asian and Hispanic descent may be more likely to develop alopecia areata compared to other ethnicities. And there are a lot of social and psychological challenges that these children face because they very much are obviously impacted. They feel isolated, stigmatized. They're often bullied because people have a hard time understanding their condition, especially when it's patchy. And really, the emotional impact we been told that it plays on our children cannot be overstated, really, because about half of teenagers felt self-conscious about their hair loss. They felt it impacted their friendships, that it led to stares and conversations about their condition, and limited their activities due to hair loss. So again, we need to keep that in mind when we're seeing our patients and addressing that for them. And we know that girls may be more affected by alopecia areata and these effects than boys. And then interestingly, and I think this is interesting and just kind of highlights that milder forms experience more bullying. And I do think sometimes what happens is, with the more severe forms, people may assume that they're getting chemotherapy or they have cancer. So of course, people don't get bullied when they have those things. But when they have the patchy hair loss is when it really looks unusual and different. So I think that could be the cause of it. But again, just something to keep in mind with the patchy variety of alopecia areata in your patients. And we do know that, again, that negative cycle of stress can make alopecia areata worse, and alopecia areata makes the worsening, makes it more stressful, and you get into the cyclical pattern of disease flare-ups and progression. And we do know that pediatric patients that have alopecia areata, they perceive stress as higher, and they have less ability to effectively manage stressful life events, including, when others approach them about their alopecia areata. And again, we do know that treatments are available and there are more and more treatments coming out, but they are not always effective. They do have their side effects. And again, that unpredictable nature is what I think really, really increases the anxiety in these patients. Ectodermal dysplasia. So as we know, the most common form of ectodermal dysplasia is X-linked. And so mostly men, because of the lionization and such, are going to manifest this disease more severely with the clinical features, and they will have more of the phenotypic findings that we kind of think of as classic for hypohidrotic ectodermal dysplasia. But girls can, there are X-linked other inheritance patterns besides X-linked. It's been shown to be autosomal dominant, and carriers do tend to manifest some phenotypic findings of ectodermal dysplasia, but they're usually not quite as severe because of the lionization and the other X that they carry to kind of balance the findings. But girls can be significantly affected. But again, broad umbrella of hundreds of different types of ectodermal dysplasias. It's about 1 in 10,000 births. Again, that X-linked hypohidrotic ectodermal dysplasia is the most common, and it is X-linked recessive, as we talked about. And the classic features of that are hypohidrosis, hypodontia. And again, a lot of times the board question is about the hypodontia. They tend to show pictures with very few conical teeth. They can have late eruption of teeth. They do tend to have hypotrichosis. And then another classic finding is the periorbital and perioral hyperpigmentation. And they tend to have this fairly young. And then because the ectodermal structures include not just the glands in the skin, it also affects the salivary and lacrimal glands. So they have decreased secretions, so they have less saliva, so they tend to eat and chew more slowly, more prone to having difficulty eating. They also have more issues with dry eye, and then they do tend to have less secretions in their airways. So a lot of times they'll get more respiratory infections because they don't have that kind of mucosal ciliary ability to expel allergens and infections. So they also get very thick earwax, and they can also get kind of almost plugging in their nasal canal just because of the decreased secretion. So anyway, we know that they suffer significantly. They do have similar measures of cognition and educational achievement. And that was a big issue in the past. People used to think that they actually had potentially less IQ, but that has been shown to be kind of misunderstood. They are more prominently at risk for febrile seizures because with their inability to sweat and cool themselves, they can have more febrile seizures, but they have not been found to impact their intelligence, but they do have an increased risk of ADHD. And then another type of ectodermal dysplasia that I studied quite a bit, and I was lucky enough to do an NIH conference that brought international physicians and researchers into this condition, and the skin biopsies from that conference way back when at Texas Children's and Baylor is still being used in research today and moving the science forward. So again, that's the great thing about being involved with these rare conditions. Not only can you easily become the expert on these conditions, but you really can impact what we know about the conditions and the treatments moving forward. So I would encourage everyone to find a rare disease to champion as a dermatologist, even if you're not a pediatric dermatologist, because that'll give you a lot of not just credibility, but it'll also give you a lot of joy in interacting with these families. So again, win-win. But anyway, we know AEC is caused by the P63 gene, and patients tend to have sparse and wiry hair, nail changes, scalp changes, and then also they can have these unique anomalies in their skin pigmentation. But the biggest issue is the scalp erosions, and a lot of children really suffer with non-healing scalp erosions. It's kind of a pathognomonic finding for AEC syndrome. You can see it in EEC syndrome. It has been reported in that syndrome, but significantly less. And again, from this conference, we got multiple publications just because it was the largest number of children that were brought together with this condition ever in the world. And really, it was just a cohort of 20 or less children. But again, because it's so rare, it's unusual to see these children together. And again, when you see them all together, things that might not have stood out otherwise, you can kind of see the pattern develop. And we found that they did have significant psychosocial comorbidities that influence not just the patient, but also their families. And parents reported kind of a higher level of functioning and psychosocial functioning for their children. They thought they were kind of at the same level as other children with chronic conditions, but the children actually expressed a more negative impact on their quality of life than their parents actually did. And I think sometimes this happens with genetic conditions because parents feel a bit guilty, like they might have caused their child's condition. And so I think they want to look at things through rose-colored glasses. And again, we all want to see our children in the best light. I can say as a mother, I do the same thing. So I think that might also impact it. But we do know that there are impacts regardless. And they found that their quality of life was similar to children living with psoriasis and atopic dermatitis, and that there are ways for us to support them through advocacy efforts, through support groups, and then tailored healthcare interventions. Atopic dermatitis, I'm going to take a sip of water here before we launch into that. So atopic dermatitis, we know that atopic dermatitis is a significant psychosocial condition, in addition to being a skin condition. And again, this is something that is all over the literature and growing, but we know that there's a high prevalence of atopic dermatitis. We know that it ranks second compared to cerebral palsy in terms of its impairment on quality of life, above renal disease, cystic fibrosis, asthma, epilepsy, enuresis, diabetes. And again, that's mind-blowing to me when I first realized that's how much our patients are struggling. And they did find that they had greater impairment in quality of life than those with psoriasis, urticaria, alopecia, or acne, or, somewhat similar for those, but it had a significant impact. And we know that if children develop this in infancy, that they're going to be in this critical period of psychosocial development. And again, most children do develop it before 5. So again, they tend to have more behavioral problems, including excessive dependency, clinginess, fearfulness, and then basically the sleep efficiency for everyone in the household is very low. So nighttime awakening, daytime tiredness. And again, that doesn't just affect the children, it affects the parents too. And it really, young mothers of children that experience this, they've shown that they have reduced opportunities outside for employment, more limited social engagement, increased parenting stress, and challenges of disciplining their children. And I think this is fairly universal because a lot of times when the patients get stressed out, the children with atopic dermatitis, they'll scratch more. And the parents know that if they scratch more, that their skin condition is going to get worse and they're going to flare it up because it's the itch that rashes, and they're going to open up skin wounds, and then they're going to be increased risk for infections. And so again, they sometimes limit their disciplining of their children because they don't want to see them scratching more, and anytime they're disciplined, they scratch more. And the children figure this out pretty quickly. And I had one mom tell me that her little one at the age of 4 would say, "I want the iPad." And if she said no, she said, I'm going to scratch, because she knew that her mother would then give her the iPad. So, they learn this very quickly. And it's not that these parents are bad parents. This is a really, really hard condition to take care of. Because again, like we've talked about in other talks on atopic dermatitis, this is such a chronic condition and it impacts every area of their life and their family's life. And it's hard to put your child in a tub when they're screaming and crying because their skin hurts. But you know, it's important to do that. And just the chronic nature of having to do the skincare regularly to stay ahead of flares. And, you know, when you put your guard down because they're looking a little bit better and you can take a breath, then it flares back up again. So again, it's really challenging on so many levels, but they did find that children with atopic dermatitis, they did have an increased risk of ADHD independent of age, sex, or comorbid psychiatric disorders. And they found that if the onset was before the age of 2, they had an increased likelihood of later onset ADHD and autism spectrum disorders at a pretty sizable percentage, 16 and 10% respectively. And it's theorized that it might be due to disordered immunologic responses, but again, that is not quite known. And there's really so much about the neurodevelopment in childhood that is still yet to be uncovered. But we do know that there's higher prevalence of depressive symptoms, increased loss of interest, hopelessness, reduced appetite, fatigue, decreased concentrating, as well as increased suicidal ideation and attempts among those with atopic dermatitis. And then there's also other comorbid psychiatric conditions, including schizophrenia, eating disorders, and OCD. And those are a subject to debate and controversy, but there are studies that show that. So I think it's really important that every patient that we take care of with atopic dermatitis, we have a conversation with them if they're old enough, and with their parents if, you know, they're taken care of by an adult in the family. EB, so epidermolysis bullosa, we know that it comes in a bunch of different types depending on the level where the genetic change affects the skin and what it affects. But it affects 1 in 50,000 children in the United States. And we know that it's that frictional trauma because they don't have that cement between the top and bottom layers of the skin that lead to blistering and severe chronic wounds that progress over time. Some of the more mild forms require little therapeutic intervention, but the ones that are more severe can require hours of daily care. And I had one child that I met through Camp Discovery at the Minnesota camp long ago, and they actually had to put her use propofol with her dressing changes because over the years they had just gotten so painful and she had developed such fear of them that to get her dressings off of her, they had to use propofol with her baths and have an anesthesiologist come into their house. So again, huge impact of this condition. And it's not just on the person that is living with the condition, but it's also on the family members and the caregivers, and they really struggle with fears for their children. It affects interfamilial relationships, and you'll find that quite commonly that the rate of divorce is more common among families where the children have skin conditions, and it leads to a lot of work and leisure restrictions for families, especially in epidermolysis bullosa. And they did find that over half of parents, sadly, would choose not to have additional children because of the significant demands that it posed because of the illness. And their parents expressed very deep concerns about the lack of understanding and empathy of others. And basically, there's so much invisible about this condition. There's so much that's obviously visible, but then there's so much that isn't seen that's below the surface. So basically they always felt like they were on duty and had a reduced capacity to provide time and attention to their other children as well, which then made them feel guilt, and they're already feeling guilt over inflicting pain. So it's just really hard. And the more we can put our arms around our patients and tell them that we're there to help them, the better off it is for them. And then again, we know there's complex challenges with children with EB. They have itchiness and painful wound care and disfigurement. And of course, they're going to have impacts from that reduce their quality of life. But what was really interesting to me is that embarrassment was the primary factor that affected their quality of life over their physical symptoms or their limitations of an activity. Those were secondary concerns. So it just really goes to show that the emotional dimensions of skin disease, especially EB, are just as important to our patients and shouldn't be overlooked. So this is hemangiomas, and this is a patient of mine from long ago, before we had propranolol. Well, I guess we had propranolol, but we didn't know it worked for hemangiomas. So we used a lot of high-dose oral steroids. Most of our kids were cushingoid, like this poor sweet baby. We did intralesional steroids as well. And so this is a superficial and deep hemangioma, sometimes called strawberry birthmarks, but we know that they're the most common benign tumor of childhood, 3 times more prevalent in females than males. And they typically arise during that first 2 weeks of life, involving the head and neck region. And we know they have that sharp increase in the growth phase, and then they have kind of a quiescent phase, and then they have the involution phase that can be quite variable over time. And in that growth phase, basically parents have significant disbelief, fear, grief, and then it really affects their early bonding with their child, sadly, because they're, again, worried about what the future holds for their child, and worried that they're going to be stigmatized later. And even if you tell them that they are going to improve with age, it's hard for them to see past the immediate, because we tend to live in the here and now and not be able to imagine the future, where these would get better. So even after involution and healing, hemangiomas don't go away. And I think that's, they improve and they reduce significantly, but a lot of times they will leave residual telangiectasias and atrophy and dyspigmentation and scarring that can impact self-esteem and self-concept. And then they did this study in children 3 to 5 with hemangiomas, and when they were compared with those without, they were more likely identified. When they were shown pictures, they pointed themselves out as the child playing alone and less likely to identify as the child that their parents liked. So those impacts happen even before we might realize. And as far as the other, children, as they get a little bit older, they start to notice those differences, and they do have decreased quality of life and self-perception when compared to others that don't have these vascular birthmarks. And then face syndrome, you guys know this, a lot of board questions come from it. The posterior fossa or anomalies, hemangiomas, arterial lesions, cardiac abnormalities, coarctation, and the eye abnormalities and anomalies that can go along with it. And as we know, they tend to be large segmental hemangiomas, and they are delays in learning in these conditions, and a lot of it is related to the vascular issues that happen, we think. And so a lot of these children do need individual education plans. So that's something to make sure to ask about, that they're getting, the educational support that they need. And then also the psychosocial distress that they feel. And they felt that it's not addressed by their physicians. So again, reiterating the importance of just assessing that and showing that you care, asking about their quality of life will, again, lead to better patient-physician interactions and make your job a lot more satisfying as a physician, helping them find the services that they need. Ichthyosis, and again, they have kind of come along with a different classification several years back, as we learn more and more about the causes of the different types of ichthyosis. But regardless, ichthyosis means fish scale in Greek, and we know that it encompasses a large group of conditions, and it can be due to changes in the DNA that cause excess production, but also decreased shedding. And, because of this, they not only get thickened skin where the cells accumulate and scaly texture, but they also have more risk, because of the skin fragility, of making chronic wounds that don't heal and get infected. So it's kind of this double-edged sword, and they're getting both edges of the sword. And a lot of our patients will develop these thickened areas over their joints, where they get contractures, especially over the hands. We see that a lot. And then a lot of, overheating because they have difficulty sweating, corneal damage due to the dry eye issues. And a lot of children end up having alopecia because of this condition as well. And we know that it can affect the self-esteem and mental health. And they saw in this study in 2020, 53 children, and 30% were found to have depression, and 37 were found to be positive for anxiety. And then they found in preliminary studies of X-linked ichthyosis, they had a higher rate of adverse mood and neurodevelopment traits. And they had higher rates of inattention, impulsivity, autism-related traits, and then distress and disruptive behavioral traits. So something to keep in mind, and discuss with the families, so that they feel kind of empowered to know that it is related to their skin condition, and it's not because these little boys are bad. It really has to do with the etiology and biology of their skin condition, and the other things that are going on during development. And then again, these X-linked ichthyosis children do have these personality profiles. And it's hard to say why and draw definitive conclusions, but again, being able to support them in this, and make appropriate referrals is really, really important. And the first organization that is a advocacy and support organization for those living with ichthyosis is an amazing organization. They're part of the Coalition of Skin Diseases. And I have the pleasure of knowing several friends that live with this condition and work hard to thrive with this condition. Morphia. This is a condition that, as we know, can also be called localized scleroderma. It can be very localized, or you can have a pansclerotic variety where it is more segmental. We know in the coupe de sable, there are more psychosocial issues that come along with that, not just the headaches and the seizures, but more psychosocial. And it does affect 2 to 3 per 100,000. And I actually think that that is an underestimate, but 3% of morphia cases are going to begin in childhood. And there are some congenital cases that have been reported. They have skin thickening, hardening, itching, discoloration. There is some newer literature coming out about being able to measure those findings so that we can see if therapies are being effective. But it's sometimes just the clinical exam is really so important in these patients, especially if they have the more pansclerotic type in regards to joint contractures. We know that there can be external triggers. We're not sure how those relate, but insect bites have been reported, injections, repeated friction, wounds, extreme exercise. And then that fibrosis that affects the underlying muscles, bones, and joints leads to the impaired mobility and growth restriction and muscular atrophy, which also feed negatively into the quality of life. And again, one study showed that the presence of morphia lesions on functionally sensitive areas, including the hands, the arms, and the legs, was related to a decreased quality of life related to those range of motion issues, contractures, and limb length discrepancies. And then again, another study showed that, there were challenges related to embarrassment, just the itchiness and painfulness of the skin, and then clothing issues that seem to exacerbate those symptoms. And there is a significant gap in the literature about understanding these in children. And again, I'm glad that they're working to develop an assessment tool to evaluate the specific challenges in this subset of our patients. And then this sweet baby, as you can see, has a segmental melanocytic nevus or a congenital melanocytic nevus, and it's considered to be large, but we know they can be giant. And, sometimes patients will have more skin that's covered by the nevus than they do have skin that isn't. And it is a therapeutic challenge as far as there are some families that want to reduce kind of the burden, the melanocytic burden, to reduce the risk of not just the cosmetic or cosmesis, but also the risk of cancers. And again, there's a lot of science that still needs to be worked out on these giant melanocytic nevi. We know a lot more than we did in the past, but there's still a lot more to learn. So if there's any young budding scientists among you out there, this is an area where I think you could have a real impact in looking at the science behind it. So again, sometimes referred to as moles or birthmarks, they can vary quite significantly in color. They tend to be lighter when the children are younger, but they can be very dark right from the start. And we know that they do have an increased risk of melanoma and the congenital lesions, and the larger the lesion, the larger the risk. But they really do come along with psychosocial concerns such as low self-esteem, anxiety, bullying, that really can affect the emotional well-being of these children and adolescents. And again, I think it's important to revisit here that, you know, the size may not always correlate, or the percent of body surface area may not correlate with the psychosocial impact, because basically teenagers at this stage in life where self-esteem and appearance is so very critical, they may be very bothered by a small congenital nevus. And a lot of, you know, people think that it's food on their face. I hear that all the time, or that it's a spotted dirt, or they have chocolate on their face. So again, it's something that gets addressed over and over and over and brought to their attention. And a lot of these kids we know want to have them removed. But we also know that they have to trade them for a scar, and they can't understand that they may not like their scar. So I think it's really important to counsel these patients well and have them understand that when we are removing them, that we are leaving them with another mark in return. And again, I'm so thankful for the noticeable shift that's happening in our societal attitudes toward beauty. I think, you know, the more we normalize skin conditions in social media, in the media, the more people understand that most of these things are not contagious, that, you know, but a lot of our patients do feel like they almost have leprosy, even though they're not contagious. And I am so thankful that these beauty standards are evolving, and I'm so thankful for the physicians that play a role in helping them evolve, and the future physicians that you are, that are going to be making our world more inclusive for these patients. And I think it's important in talking about that when you go out and open your own practices or join group practices, a lot of these kids come into these offices that just have pictures of beautiful people. And I think it's fine to have pictures of beautiful people in our offices, but we also have to have pictures of people that look like us, and aren't the beautiful people, so that our patients can feel comfortable in the spaces they're coming to, because they're already coming in feeling vulnerable. So again, I think the more that we can be inclusive in our waiting rooms, and show things that normalize skin conditions, I think we're helping be part of the change. So again, lots of hope that we are going to make a difference collectively as dermatologists out there in the world and as healthcare providers. Psoriasis, we know that there's a lot of psychological issues with this. And again, the severity doesn't always correlate to the impact that it has. 3% of the population is affected, and it's quite visible in a lot of patients, the majority of patients. It can affect the scalp, can lead to hair loss, and that leads to emotional stress because people feel unattractive and frustrated. And then again, this stigmatization of society can lead to misconceptions that it is, you know, contagious. And one large-scale study showed that again, adolescents with psoriasis, when compared to those without, the children with psoriasis were more likely to visit the emergency room for anxiety disorders and depression and mood disorders as compared to their age-matched peers. and there was a significant association to schizophrenia, impulse control disorders, adjustment disorders, and personality disorders. So again, there is subjective data to show that. So I do think it's important to screen for those things. And again, chicken and egg, how are they related? The story is yet to be fully written on that, but we're learning more about it every day. And again, another study that just looked at 6 common themes that reflect the anxiety experienced by these children, including body concerns, feeling of isolation, frustration, worries, effort to hide their skin, and then concerns related to treatment. They looked at those, and there was a positive link between that and the emergence of anxiety and depression. So again, something that can kind of feed into that cycle and kind of create that negative spiral as well, because they can each worsen one another. Vitiligo, again, I see a significant amount of distress among parents and children with the initial diagnosis of this condition, because it is so apparent and makes their children stand out so significantly. So again, these families are very much worried about what the future holds. Again, so thankful for the increased armamentarium of treatments that are coming to market for this condition, as well as alopecia areata. But again, we know those treatments do have their own side effects and they're not uniformly effective yet, hopefully one day. But, you know, again, this is one where the severity also doesn't always correlate with the degree of psychosocial impact. It is chronic, and again, it has those periodic flares, and it can affect anywhere between 0.5 to 2% of the population. And we know that when people go out into the world, they do face stigma. And there was some thought that it was related to leprosy in the past. And again, you can't get dyspigmentation with leprosy. So again, there is some scientific reason that that has been developed, but we know that that isn't the case with the autoimmune disease of vitiligo. But we know that those patients that wear this condition and live with it have increased anxiety and depression compared to those that don't have anxiety. And we also know that there's a correlation between this condition and ADHD, that 90% had at least one psychiatric diagnosis compared with 20% in the control cohort. And over a third of vitiligo patients had a diagnosis of ADHD. So again, definitely some correlation there. We also know that because of this the stigma that they are discriminated against when they interact with others in public, and they really have a lower quality of life that not only affects the children, but also the parents. And they did find that it is worse if it's on the face and also on the hands, because a lot of people, again, if somebody goes to shake their hand and they have vitiligo, a patient will, or a person that's going to shake their hand, when they see it, they may retract because they think it's contagious. So again, puts that big social divide between those living with this condition and the rest of the world. And again, I just want to tell you thank you for all the work that you do as future dermatologists, healthcare providers. The work that we do can be hard and difficult, and burnout is high, even among dermatologists. Even though we have such a privileged job, it's still hard. And there's a lot of demands on our time and our energy. But again, the more we can connect with our patients and one another and lift each other up, we are better together. So I just want to thank you for the time that you put into taking care of your patients, not just the medical and the physical aspects, but also the social, emotional, and the spiritual aspects that may arise for your patients. And I just applaud you for the care that you're providing each and every day. So keep that up. And again, we know you're not alone. Or I want you to know you're not alone, that, you know, these burdens are heavy and some days they're heavier. And there is an increased risk of suicide among physicians. And I think that we need to really help one another, lift each other up, and not have this be a stigma. And if you need help, reach out to your colleagues, reach out to your friends, reach out to your family. There are free resources out there that are confidential that I've listed here. And again, you're not alone in taking care of your patients. There's patient advocacy groups that love on these patients well. And again, some days it's just so overwhelming to get through the day and just get through your clinic and get through the stack of emails and phone calls and prior authorizations that you don't have a whole lot to give even to your family, and certainly a limited amount to give to yourself. So make sure to reach out to people when you need care. Remember that self-care is not selfish. And then refer your patients to groups like Made a Masterpiece and all of the different Coalition of Skin Diseases organizations, because they're there to help as well. So again, a little bit about Made a Masterpiece. You guys hear me talk about this all the time, but I can't help it because I love it. Our mission is to empower those impacted by skin conditions to face the world with confidence. And we do really envision a world where we're all seen as the masterpiece pieces we were created to be. We did go through a big transition about a year ago, as some people know, from our physical location in Houston as a Children's House for the Soul to our online exclusive presence with increased resources online. But we are meeting the children and teens where they live, which is online and on social media platforms. So we're growing those all the time. But if you ever have any questions or want to get your patients engaged, please give them our website, give them our email, our phone number. Would be happy to love on them and help provide them the support that they need. And again, why we exist: 1 in 5 children is impacted by a skin condition or birthmark. And again, those social, emotional, developmental, and psychological challenges that they face, leading to low self-esteem, diminishes self-confidence, and decreased social interactions, is what drive us forward. And we know, again, as we just talked about, that they have an increased risk of anxiety and depression, but sadly, suicidal thoughts are 44% more common, and suicide attempts are 36% more likely when living with a chronic skin disease. And that's why we exist. And again, we do have a great friend in Coco Cares. They have an amazing link that they have provided us for our community with skin conditions, where they can get free psychologic resources and plugged into people that can really help. So again, I think this is a great way for patients to get resources that they need. And then again, we are the only 501c3 in the whole United States exclusively dedicated to providing social, emotional, and spiritual support for those living with skin conditions of all types. And we really do want to be a beacon of hope and healing for those with skin conditions, so they know they're not alone. And we really view the skin as a masterpiece, both inside and out. The microscopic images that all of our friends at Sages get to look at underneath the microscope. And as our official sponsor, it Made a Masterpiece, but it really is an amazing canvas with unique colors and patterns and textures. And again, microscopically, it's equally as beautiful. And our ability to help our patients will really help them see it as a masterpiece, hopefully too. Other patient support resources, again, I think these are really important: Coalition of Skin Disease, Society of Pediatric Dermatologists. My colleagues in PediDerm are amazing. I have so many heroes among the pediatric dermatology community. Please refer your patients to Camp Discovery through the Academy, also Camp Wonder. They're both wonderful camps. And again, these are some of the quality of life measures. The Children's Dermatology Life Quality Index that is out there and has a pretty short form, and they have a pictorial version for younger children. Again, Society of Peds Derm has support for families, child life specialists. I think these are great resources. And then I really love this celebrating our stories. So Courtney Westlake, her daughter was born with Harlequin ichthyosis, and she's just an amazing advocate for people with differences. And I really like this resource. So congratulations, we've made it to the end of this talk. We are going to be putting this up on our website, on the Made a Masterpiece website, and you can take the quiz. You've already gone through it with me, so you don't even need to read through the educational module. But when that quiz is up, just go ahead, take it. It's a Google Doc. You'll get your certificate right afterwards, and then we'll send you a badge with your name on it that says you're a Masterpiece Patient Advocate. So thank you for your time. And remember too, that you were made a masterpiece. So take care of yourself as the person out there helping others love the skin they're in. We thank you so much. We will look forward to seeing hopefully lots of you at Texas Derm coming up this weekend. And then next week, we're going to be looping in some speakers from the Coalition of Skin Diseases. So in the next couple of weeks, on our next time, we're going to be looping them in, and I can't wait for you guys to hear from the patient perspective. So thank you for your time, and reach out if you need us. Bye.